Otherwise, we will be going ahead with the today's class. Any quick questions from the last class? Okay, so let us start today's session. So first is your bony anatomy. So the bony anatomy in the elbow has this the lower part of the humerus, which is being joined with the radial part and the ulnar part. So this side, lateral side, where the radius is connecting with the lower part of the elbow, this part is known as the capitulum. And this part of the joint is known as the radiocapitular joint. And this is basically inverted U or inverted or C-shaped. You see, this part is like this and elevated. And this part of this lower part of the elbow is known as the trochlea. And it connects with the ulna. So this is radio ulnar joint. Sorry, the radio ulnar joint. This what is this part of the joint? Series.
Radiocapitular, sir.
Radiocapitular is this part.
Radiocapitular. Allotrochlear.
Allotrochlear. Right. So there are two fossas here. One fossa is this is where the radius head is coming. So this fossa is known as the radial fossa. And this fossa is known as
olecranon fossa.
No, olecranon fossa is behind. So this is your coronoid process will be coming here. So this is your coronoid fossa. So radial fossa and the coronoid fossa. Okay. So this part, when we'll be holding the probe here, we'll be seeing this capitular part and the trochlear part, and we'll be able to see this part of the joint. Though the details of this part is not there in the basic, but some part definitely will be covering today. Then is here on this bony projection is your lateral epicondyle. So here the common extensor tendons are getting attached here. And this is on the area where the tendinosis of the common extensor tendon is known as the tennis elbow. So that can happen here. And on this side, on the medial side, we are having the common flexor tendons. So 4 common extensor tendons and 5 common flexor tendons, which will be getting attached there. And if there is a tendinosis, that is known as the golfer's elbow. Olecranon fossa is posteriorly. So this is the olecranon fossa, where the olecranon process of the ulna is entering into this olecranon fossa. Okay, so this much is the bony anatomy here. I am not going into the detail of the tendons or these nerves and the muscles there. Muscles I'll be showing. Okay, let me put the muscles there, because anterior elbow, one very important part is your muscular part. So here we will be holding the probe anteriorly over this elbow crease. And if you are holding the probe over the elbow crease, what we'll be seeing? We'll be seeing on the top, this is your biceps. So biceps tendon, and as you know, there are 2 heads of the biceps. Lateral side, this is a long head. Medial side, this is your short head. So they are together, will be forming the biceps, distal end of the biceps tendon, which will be getting attached with the radius. So on the top, we'll be having the biceps. And just medial to that, so this is also, there is a mnemonic, which is known as the BAM. So after the biceps tendon, the next important structures I should be seeing there is your artery, the brachial artery. And then there will be nerve, median nerve. So BAM, the biceps tendon, the artery, and the nerve. So they will be arranged in a row from the lateral to medial. And just below that, this was the short head. I'm just removing both short head and the long head and the bicipital aponeurosis. So this broad pyramid-shaped muscle is your brachialis. So anteriorly, we'll be having the 3 muscles. From the lateral, this is your, what is this muscle? You can tell?
Common extensor.
No. Common extension is the lateral side, here.
Brachioradialis.
Brachioradialis. This muscle is your brachioradialis. Recently, I have posted this in the Daradia Fellows group also, putting a question mark here, what is this muscle? So on the lateral side, we are having the brachioradialis muscle. And then comes your, what is this muscle? big broad muscle just now I told?
Brachialis.
Brachialis. So one on the lateral, then on the middle, the big one, and then there is another on the medial side. What is this muscle?
Pronator teres.
Pronotal teres. So if you're holding the probe here in the distal end of the radius over the skin crease, we'll be seeing these three important muscles. Brachioradialis, brachialis. Brachialis is the most bulky, occupying the whole, almost whole of the elbow. And on the medial side, we are having the pronotal teres. And then on the top of this brachialis, as I told, the three structures are sitting from lateral to medial. What are those? BAM. What are those?
Biceps tendon, artery,
Biceps
and
tendon.
median nerve.
And there is another nerve between the brachioradialis and brachialis in this group. What is that nerve? Is your radial nerve. So the two divisions of the nerve, the superficial and the deep, that will be lying between the brachioradialis and the brachialis. So that means you will be seeing anteriorly, what are the things you'll be seeing? We'll be seeing the three muscles, brachioradialis, brachialis, pronotal teres. We'll be seeing two nerves on the either side of the brachialis. Lateral side will be having the radial nerve, medial side will be having the median nerve. And on the top, we'll be having the biceps tendon and the brachialis artery. Okay, brachial artery. So these are the things what we'll be seeing in the anterior elbow. Medial elbow will not be going to the detail of the ligaments and the tendons here because it will be a little bit more complicated, which is beyond this basic course. And that is your common extensor flexor tendon on this medial side and common extensor tendon on the lateral side. So this much in the elbow. Okay. Anything you wish to see again? Anybody? Detailed ligaments complex and the other nerves we are not covering in this basic course because, you know, if somebody, we are having already some of the lectures are there in the YouTube channel, you can go ahead and check those things. But here we'll be covering this much in the anterior, in the elbow. The common extensor tendon, common flexor tendon, and anterior elbow, the structures that you can see in the anterior elbow. Right? Now let me go to the wrist. Let me remove all these structures first. First, bony anatomy. Okay, so here in the wrist, so distal end of the radius on the lateral side, the ulna on the medial side, and then we are having the carpal bones. Carpal bones, just remember the mnemonics. Recapitulate. C looks too pretty. Remember, scaphoid, lunate, tricutrial, pisiform. And it is like an inverted, you know, I normally ask to remember like this. So this proximal row is like an inverted C. See, this is like an inverted C. And this is your scaphoid, then middle lunate, then your tricutrial, and then over that pisiform. So it is an inverted C. And then there is an inverted T. Inverted T. Inverted T, it starts with trapezium, trapezoid, capitate. Capitate occupies the middle of this, whole of this. And then we are having the hamate. So trapezium, trapezoid, capitate, hamate. This is the distal row. Okay. So now here, what is important for us, what we discussed in the basic course is the proximal carpal tunnel. So carpal tunnel is formed by what? The flexor retinaculum. And it's the divide for our convenience two part. Proximal carpal tunnel. Proximal carpal tunnel is here between the scaphoid and the pisiform. And the distal is here between the trapezium and the hook of the hamate. So this is your distal carpal tunnel. Distal carpal tunnel is little narrower than the proximal carpal tunnel. So the proximal carpal tunnel, the either side, there are two pillars. On this side, lateral side, or we can call the radial side, we are having the pisiform, we are having the scaphoid. On the medial side, we'll be having the pisiform. And what will be the base? Base will be by capitate and hamate, not the lunate. This is very important that when we'll be scanning from here, we'll be seeing what? Radius and ulna. And there one muscles will be there, which is lying like this. That is your pronator quadratus. Pronator quadratus is all other nostrils are like this in the long axis, but this is, it is in the horizontal. So we'll be starting from there, scanning, and then we'll be coming down. When we'll be coming down, we'll be first seeing this bone, most elevated bone will be a lunate. So that is not the area of the carpal tunnel. You have to go still more further till we get the two pillars. So these two pillars are one side scaphoid, another side pisiform. And base will be formed by your lunate and the hamate. Base is by lunate and hamate. Sometimes small part of the triquetrum also can be seen here. And what are the contents? Okay, another thing is, on the pillar, two pillars, there will be two tendons running. This side is your flexor carpi radialis on the radial side, and this side will be your flexor carpi ulnaris on the either side. And then the contents are most important, the middle part will be your median nerve, and then there will be 4 flexor digitorum superficialis, 4 flexor digitorum profundus, and on the thumb side, we'll be having the flexor pollicis longus. So these are the 9 tendons and 1 nerve. These are the content of the carpal tunnel. So this will be showing, demonstrating today that what are the contents, what are the boundary, what is the roof, what is the floor. So this of the carpal tunnel. Carpal tunnel is one of the very common, most common nerve entrapment is the median nerve entrapment at the carpal tunnel. And that is one of the very commonly done procedures also. So we'll be discussing that part. Then we'll be discussing the dorsal compartment, first dorsal compartment. So there are how many dorsal compartments?
6.
Okay, so there are 6 dorsal compartment. So first compartment is most radial side, first compartment. And the first compartment, there are 2 tendons. It starts with, remember, like this. It starts with A, first alphabet, and ends with L. Rest all will be starting with E and ending with B, L, B, like that. So first is your A, and it is going to thumb because that is going the radial side. So that will be abductor pollicis longus, and then extensor pollicis brevis. So these are the 2 tendons of the first compartment, right? So first compartment, abductor pollicis longus, extensor pollicis brevis. Then second compartment will be having the 2 tendons, and it will be starting with E, ending with L, and then again E starting with B. So it will be that extensor, this is the radial side. So extensor carpi radialis longus, extensor carpi radialis brevis. ECRL, ECRB. So this is the second compartment. Okay. Then will be coming the Lister tubercle. And after that, it will be having the third compartment. Third compartment, again, it will be starting with E and ending with L. Remember that the third compartment is again coming on the thumb. So it will be extensor pollicis longus. Only single compartment at the third compartment. Then the fourth compartment longus brevis will not be there. So fourth compartment will be having the 2 tendons. One is extensor digitorum. Extensor digitorum, though it is having the 4, so we can call it as a 4 extensor digitorum, and below that will be having the extensor indicis. So extensor digitorum and extensor indicis will be the fourth compartment, will be extensor digitorum and extensor indicis. That is the fourth compartment. Fifth compartment, only one, extensor digiti minimi. And sixth, again only one, extensor carpi ulnaris. So these are the 6 compartments, and the first compartment 2 tendons, second compartment 2 tendons, third compartment 1, fourth compartment 2, sixth 1, and fifth 1, and sixth 1. So let us quickly see. Though in the here we will be having only I'll be concentrating mostly because this is a basic course. So I'll be concentrating mostly on the first compartment, because first compartment interrupted by the, and it is all covered by the extensor reticulum. So this side it was covered by the flexor reticulum, this side by the extensor reticulum. And why this compartment? There are actually partitions from the extensor reticulum, which will not be allowing the tendons of one side mixing up with the another compartment. No jumble up of the tendons, and that is the reason why these compartments are important. And here the very important bony landmark is this one. This is your listed tubercle. So listed tubercle divides the second compartment and the third compartment. Third compartment is your extensor pollicis longus, you see, it's going to the thumb. So this listed tubercle on this side, second compartment, this side, third compartment, and then we'll be coming to the first compartment. These are the two first compartment. And this is all covered by the extensor reticulum with the partitions between this compartment. So these are the second compartment tendons. And then we'll be coming, first compartment tendons. And after that, we'll be coming to the trigger finger. So trigger finger, we are having, let me put the connective tissues. So in the trigger finger, so this is your annular pulleys. How many annular pulleys? 5 annular pulleys. So 3 annular pulleys are on the 3 joint, that odd numbers are over the joint. That means A1 over the metacarpophalangeal joint, A3 over the interphalangeal, proximal interphalangeal joint, and A5 over the distal interphalangeal joint. So A1, A3, and A5. And in between, this is your over the shaft A2 and A4. So A1, A2, A3, A4, A5, 5 annular pulleys. And these crisscross pulleys are known as the cruciform pulleys. Cruciform pulleys may be 3 or 4. So C1, C2, C3, C4. So these are the cruciform pulleys. So our interest will be over this one, your annular pulley, A1 pulley. Because annular pulley, A1 pulley, if it is thickened, then the condition is known as the trigger finger. You see, these tendons, then flexor digitorum superficialis and profundus, they runs through these pulleys. So if there is a thickening of this A1 pulley, the tendons will not be gliding forward. And this condition is known as the trigger finger. So the A1 pulley, you see on this either side, there is a palmar plate. There is the cartilaginous plate. So which you'll be seeing that. So if you are holding the probe from here, what will be structures will be seeing? After the bone, we'll be seeing this cartilage. This is fibrocartilage. Now, other day we discussed, to remember, that the fibrocartilage looks white and the hyaline cartilage will be looking black. So this is fibrocartilage. So it will be looking white. And over that, we'll be seeing the tendons, flexor digitorum and the superficialis. Tendon will be seeing profundus and superficialis. And over that, we'll be seeing the A1 pulley. So this much is today's topic. In the 3D anatomy, if you wish to see anything again or anything clarification, you tell me. Otherwise, I'll be going to this, the demonstrate on the volunteer. Any questions
Sir,
from
can you
anybody?
please show the annular pulleys once again, sir? And
Okay.
the tendons you just mentioned, flexor digitorum.
There are 2 tendons, flexor digitorum superficialis and flexor digitorum profundus. Superficialis will be running superficially, and below that will be having the flexor digitorum profundus. So these are the annular pulleys. These are all of the annular pulleys. Annular pulleys, I told you, 5 annular pulleys. So some over the joints, you see, this is over the joint, metacarpophalangeal joint, then proximal interphalangeal joint, distal interphalangeal joint. So odd numbers, A1 over the metacarpophalangeal joint.
Metacarpophalangeal joint.
A3 over proximal interphalangeal joint. And A5 over the distal interphalangeal joint. Then comes the even numbers. A2 over the phalanx. Which phalanx? Proximal. And then A4 over the middle phalanx. So 1, 2, 3, 4, 5. So 5 annular pulleys. And these are the cruciform pulleys. Cruciform pulleys can be 3 or 4. So these are the cruciform pulleys in between the annular pulleys. Okay, clear?
Okay, sir.
Any other questions from anybody? Okay, so give me 2 minutes time. Today I have already set up the things early so that I can start quickly. Okay, chala. Okay, I hope you can see my volunteer.
Yes, sir.
Okay, I'm just making the light little better. Take it.
Now it's better, sir.
Okay, so elbow is extended and two cameras are there, one from this side, another is the other side. So first what will be, see, this is the elbow crease, so I'll be putting the probe here. And as soon as I'm putting the probe here, what is very important that I'll be seeing some, the highways, running there. And that is your the articular cartilage over the distal end of the radius. And how the articular cartilage will show? Will be black or white?
Black.
It will be black because it is hyaline cartilage. Okay. I'm putting my aspect marker on the lateral side. That means left-hand side of my screen is the lateral side of the screen. Lateral side of the patient. Okay. So I'm putting over here and I am just searching for this one. Can you appreciate?
Brachial artery.
No, I'm not asking you to look at the brachial artery. I'm asking you to look at this hyaline cartilage. Okay. So let me mark it. So what is this black line? This is the
Hyaline cartilage.
hyaline cartilage of the distal end of the radius, right? And as we told, can you remember? There are two parts. One is inverted U or C, and another is your U. So this part is known as
Radiocapitular.
this part is known as capitula,
Capitula.
and this part is known as
Thoracic.
Trochlea.
So this forms the radiocapitular joint. Okay, and this part forms the ulnotrochlear joint. Okay, so these are the two parts in the distal end of the radius, and you can see this whole big muscle, pyramidal shaped muscle, with some, this. What is this muscle?
Brachialis.
Brachialis.
Brachialis. Very good. And there are two other muscles you can see on the either side. One is small part of this muscle on the medial side, and one is small part of this side. So what is this muscle?
Pronator teres.
Lateral side.
Brachioradialis.
Brachioradialis.
Brachialis.
Medially
Brachio
pronator teres.
and this side is your medial side. Pronator teres. Okay. So now what else we can see here? We can see here. This is your
Biceps.
Biceps.
Biceps tendon.
another things you always remember. The biceps as the lateral side will be having one head, another side, the medial side will be one head, and they will not be, most of the you'll be seeing the long head, and this is the long head, and this is the short head. And there is some artery here. What is that?
Brachial artery.
Brachial.
And this is the one nerve there.
Median nerve.
Median.
Medial nerves.
Okay. Is it clear? Anterior elbow, what we are going to see? Again, I am scanning, and again, I am showing the structures. So you see how to start, where to start. So you over the skin crease, elbow crease, and you just go up and down till you see this very nice highway. So once you are seeing this nice highway, that is the home page. So you start from here. So if I am going on this side, we can see the brachioradialis muscle is very nicely. And in between the brachioradialis and this, can you see the two important nerves, black dots?
Superficial and deep branch of radial nerve.
Very good. So these are the radial nerve in between the brachio. This is your brachioradialis and this is your brachialis. So in between that, in this facial plane, we are seeing the two branches of the radial nerve. So this is superficial and this is deep. And now I am going little more on the, so again, home page. This is very important, home page. And then over this, I can see the two heads of this. So this is your what?
Biceps tendon.
Biceps tendon. Then brachial artery. And you can see the median nerve very nicely. Honeycomb-like appearance, big nerve, honeycomb-like appearance. So that is your median nerve. And then this muscle is your pronator teres muscle. Okay, pronator teres, if I'm going more medial, you'll be seeing the pronator teres muscle very nicely. So this whole is your pronator teres muscle. So this is your anterior elbow. Clear? Now I'll be going to the medial and lateral elbow. So first let me go with the medial elbow. Medial elbow, what we are going to see? We are seeing the nothing. So normally the medial side is better seen if your patient is supine. Otherwise, normally this is a little bit of awkward position. So what I'll do, I'll be palpating the so this is your medial epicondyle. Medial epicondyle, and I'll putting that aspect marker means the over the, that means proximal end. Left hand side is the proximal side. So what I can see here, I'm teasing it.
Common flexor origin.
So
Common
this,
flexor.
okay, this picture is not, let me show you some. Another very important things to remember, you look at my probe position. If my distal end of the probe is towards the little finger, this side, then I'll be seeing the ulnar,
Flexor carpi ulnaris.
then I'll be seeing the ligaments nicely, not the tendons nicely. Okay, so these are the basically the ligamental part. So anterior band of the medial ligament complex. And if I am tilting my probe, distal end of the probe towards the thumb side, then I'll be seeing the tendons better. Can you appreciate that now the tendon is seen better? So here, when I was holding it like this, then I was seeing the ligaments better. You see? Now the ligaments are seen better. This part is your ligamental part. Anterior band of the medial ligament complex. But if I'm holding the probe like this, then I am seeing, so I have done what I have done. I have done a little bit of tilting of the distal end, not the proximal end. So this was the ligament part, very nice ligaments part at condition. And if I'm tilting my probe towards the thumb side, you see now the muscles and tendon part is very seen very nicely. Can we all appreciate? So this is the common flexor tendon. This is the myotendinous junction. So this part is your anterior band of the medial, the medial ligament complex. So here, if you are doing the, the procedures, so what do you have to do? Your needle should come like this and do the multiple fenestrations at the different angle and give the PRP injection. Steroid injection was earlier given. If you are giving the steroid injections, then what we have to remember that in this plane, in this, some black areas, can you see? So in this plane between this, the tendon and the ligaments, you can give injections below that tendon and superficial to the tendon, this area. Not within the tendon, steroid is recommended. But nowadays, steroid is not the choice. Choice is your PRP, platelet-rich plasma is the first choice. So you give injections anywhere and do the multiple fenestrations also at different, changing the angle. So this is for the golfer's elbow. Everybody appreciate?
Sir,
Understood?
Sir, excuse me, sir. Sir, what will be the position during the injection, sir?
Position will be like this. Patient will be lying supine. Patient will be lying supine and the elbow position will be like this. Okay.
Yes,
You can do in the sitting posture also, like the patient is sitting here like this and my needle will be going like this. right?
Okay, sir.
The
Thank you.
needle direction caudal to cranial.
Caudal to cranial. So needle will go like this. Means this is the cranial side, no? This is cranial side and this is caudal side. So needle will be coming like this. Caudal to cranial, distal to proximal. Clear?
Okay, sir.
So let me go to the now. Now to the lateral side. Lateral best position is sitting posture. But again, one of the things to remember that in sitting posture, some patient might be having the vasovagal attack. So always be cautious about it. So here, what will be doing? Position of the patient, thumb will be looking up towards your roof, up, and you'll be seeing the palpate, little bit of flexion and of the elbow, and I'll be palpating the lateral epicondyle, and I'll be putting my aspect marker over the lateral epicondyle. And this is the picture what I'm going to get. So aspect marker is towards the condyle. So my left hand side of the screen is your condyle. Okay. So here you see, this is the lateral epicondyle. And this part is radius. This joint is what joint? Who can tell?
joint.
Radiocapitular joint.
Radiocapitular joint. Very good. So here also you see, this part is your ligamental complex. The upper part, if you are dividing this slope, the upper part is the common extensor tendon. And the lower part, this part, is the lateral ligament complex. Okay? There will be annulus ligament here. And the radial collateral ligament will be here. And above that, this is your common extensor tendon. So how to do the procedure? So needle will be coming from proximal to, distal to proximal, like this. And again, multiple fenestration is important. So you do the multiple fenestration and inject the PRP. PRP is again the choice. If you are giving steroid, steroid should be below the 10 again. So I'm just showing you again. Just check. So distal end, proximal end, I'm putting it over the condyle, and the distal end is towards the radius. So you can see the upper part and the lower part ligaments are very nicely seen. So this is your common flexor
The
tendon.
position of aspect marker is towards cranial.
Towards cranial side. Means left hand side is the aspect marker side. That is your proximal side, left hand side of the screen. And the right hand side of the screen is the distal part, radius part. Okay?
So, sir, during injection, do we target also ligament or only tendon, sir?
Only tendon. If there is a ligament injury, then you target ligament. If the ligament injury is not there, why to target the ligament? Okay?
Okay, sir.
Ligament, when you are targeting the ligament, there is specific indications. If you are finding there is a sprain of the ligaments, then you can do the target the ligament, PRP injection can be done.
Sir,
But this
alter-
part,
yes, sir.
this part, above part, this part is your tendon part. And this part is your ligament part. This is annular ligament. So whole ligament, there are three parts of this ligament. Lateral ulnar collateral ligament, the radial collateral ligament, and the annular ligament. These three together is known as the lateral ligament complex. So these are the two parts of the ligament. So here is not our target unless there is some injuries. You can see some black lines, and that is the part dividing it. So this part is your tendon part. And this part is your ligament part. Clear?
Thank
Sir, can you please mention what are the ligaments in lateral ligament complex?
That is not here in the syllabus. Anyway, so there are three ligaments are here. And three ligaments are your what? Who can
Annular
tell?
ligament?
Some 1 year fellows are there. Let me hear how others can remember because we have already covered this in the MSK class.
Sir, annular ligament,
Mhm.
lateral ulnar collateral ligament, and radial collateral ligament.
Right. So here, what we can see here, this is your radial collateral ligament, which is intermingling with the annular ligament. Here is annular ligament. And the lateral ulnar collateral ligament comes from lateral epicondyle towards the ulna, like this. Like this. Okay. Somebody is asking, so let me show you. So if I am holding the probe from here, this is the ulna. Okay. So this is your lateral ulnar collateral ligament.
Lateral ulnar column.
Okay. So these are the three part of the ligament, medial ligament, lateral ligament complex. So same way, medially also there are three part of the medial ligament complex. Anterior band,
Anterior band, posterior band, and medial.
Sorry, posterior band and
transverse. Transverse or horizontal band. Okay. So elbow is okay. This much is there in the syllabus of the basic course. Medial side, we are having the common flexor tendon, common extensor tendon, and anterior elbow. Now let me go to your median nerve, carpal tunnel. That is most important part because that is very, very common. Golfer's elbow, tennis elbow also very common. But this is one of the areas. So now again, I'm putting my aspect marker towards the lateral side. Means radial side is here on the lateral side is radius. So if I'm starting my scanning from here, so what we can see here, this is your radius, this is your ulna, and this is one muscle running like this. What is the name of this muscle I just now told during the... What is that muscle?
Pronator
Very good.
quadratus.
Now I am coming distally. Pronator quadratus is vanished. Still radius and ulna is seen a little bit. Radius is also vanished. Now some bone is appearing. So what is that bone? Two bones are basically appearing.
Lunate
Radius and
and
ulnar.
Lunate and hamate.
This is your scaphoid. This is your lunate.
Acha.
So now I am going still distally. And now I have entered into the carpal tunnel. So now you see, tendons are not seen nicely, but let me explain what I can see here. So what is this? On the lateral side, I told you two
Scaphoid.
pillars. One pillar this side, one pillar this side. So this is your scaphoid. And what is this?
Scaphoid. Pisiform.
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 And what is this bone?
Capitate.
Capitate.
Capitate. What is this bone?
Hamate.
Lunate.
Hamate. Lunate cannot be seen in the carpal tunnel. Don't make this mistake. And a small part of this bone is your
Trapezoid.
tricuspid. Why are you making the mistake? Okay, let me quickly go to this. I'm just stopping sharing here. Just don't make this because, you have to understand this very nicely. I'm going to show you the again, bony anatomy nicely. Don't make the mistake again. Just look at where is the carpal tunnels and what are the boundaries there. What is the floor and what all the other things are there. Just somebody's phone is ringing. Please remain muted. Please remain muted. Okay. So what I told, carpal tunnel is here. Proximal carpal tunnel. So on the radial side, this bone is,
Scaphoid.
and on the ulnar side, this bone is your
Pisiform.
And the base is by this bone is your
Capitate.
capitate. This
Okay.
bone is your,
Hamate.
and this small part of this bone is your. Understood? That is your triquetral. Because you just remember this bone nicely. Scaphoid. What is this?
Lunate.
Triquetral, pisiform. Trapezium, trapezoid, capitate, hamate. So the base will be by mostly by the capitate and hamate, but small part of triquetral might have also be seen. So now I am coming back to this again here. So what I can see here, I'm clearing the drawings again. Try to relate. So this is your, this side was your, this is the radial side. This is the ulnar side. So scaphoid. Then what is this bone?
Capitate.
Capitate.
Bone.
Hamate.
What is this one?
Triquetral.
Triquetrum.
What is this?
Pisiform.
Pisiform.
Very good. Okay, see again. So I was starting from scanning from here. Pronator quadratus, radius, ulna. And now I'm going distally. So this is scaphoid and the radius and the lunate is coming. So this is not carpal tunnel. You can see the median nerve very nicely on the top of this. This is median nerve, but this is not the area to do the procedure here because we have not yet entered into the carpal tunnel. Now I am going more distally. Now I have entered into the carpal tunnel. And you can see that now the boundary is on the other side and I can see the base. So now what I'll do, I'll be just, you see, from tilting, the lunate is coming. So that is the area where it is dipping down and then there is anisotrophy. So
Sir, what should be the position of wrist? Is it neutral or little bit
it is little
extended?
bit, if a little bit flexed, slightly flexing, then you'll be seeing it better. You see, if I'm flexing it, because it is dipping down, you see now the tendons are structures are very nicely seen. এরকম রাখ, হাতটা ভাঁজ সোজা করিস না, একটু ভাঁজ করে রাখ, কবজিটা ভাঁজ কর। Okay, so you see here I can see the tendons very nicely, but if I'm going down, then seeing the tendons might be difficult. Okay. So again, coming back, so what I can see, scaphoid, pisiform, lunate, hamate, triquetral, and median nerve will be seen here, and there will be 8 tendons and 1 tendon here. That is your within the carpal tunnel. One apart from the 4 flexor digitum superficialis and the flexor digitum profundus. Another tendon is, who can tell the name?
Flexopolisis.
Exorpolysis.
Flexor pollicis longus. And 2 other tendons outside the carpal tunnel. This is the carpal tunnel. No, this is the flexor retinaculum. And this is 1 tendon. This is 1 tendon. What are these tendons?
Flexor carpi
radialis
and flexor
and
carpi
flexor carpi.
radialis.
Radialis, flexor carpi, flexor carpi radialis, FCR, and flexor carpi ulnaris, FCU. So FCR and the FCU. So they too are tendons which are standing like a guard, you know, over the pillars it is sitting. This is the tunnel, pillar. This is the base. And this is the content of the carpal tunnel. Okay. So again, see, I was coming from here and now here. So I am into the carpal tunnel now. And I am just tilting a little bit. And I can see the tendons. So at this position, I am asking the patient to move the thumb. And you can see the flexor pollicis longus is moving. Can you appreciate that? And in the middle of my
Yes,
screen, the aspect marker is your median nerve. Can you all appreciate the median nerve?
Yes.
So this flexor carpi, sorry, flexor carpi ulnaris is here.
Flexor helecis.
Flexor
Flexor
pollicis longus.
helecis.
And this is
Helecis.
and this is your ulnar nerve, median nerve. Sorry. And you can see this black
Sir,
and white.
can you just show the tendons again, sir? Contents.
I'll be showing. So first you look at this, the median nerve. So for the hydrodissection, your needle should be coming like this or coming like that. Go above and below the nerve and do the hydrodissection. Okay. So flexor pollicis longus you wanted to see again. So what you have to do, you just
Yes,
see
sir.
the carpal tunnel there and can you appreciate the movement of the flexor pollicis longus?
Yes, sir.
Just this is on this
That
one.
is inside carpal tunnel.
Yes, carpal tunnel is see, this one is your flexor retinaculum. And this ulnar artery and nerve, this is the Goenz canal. That is outside the carpal tunnel. Remember that. Ulnar artery. So you can see this, if I'm tilting, the flexor retinaculum is very nicely seen. And you see, this is the flexor digitorum superficialis and the profundus tendons. These are.
Excuse me,
And
sir.
median nerve. Yes.
Sir, please explain the hydrodissection of median nerve, sir. I missed it.
The middle will be
It is
coming like
inside.
this, below the nerve and above the nerve. So first you do go above the nerve or below the nerve, whatever it is, but you have to puncture this flexor retinaculum. That is very important. Puncture it and go closer to the nerve without damaging the nerve. This video is there in your YouTube channel in your dashboard. So please look at this dashboard, this how to do these things. And very recently, we have also posted another video in our Daradia fellow Facebook group also. Please go through that video as well. So here we are putting needle there, going injecting here, and the nerve should be floating in the water. Dextrose is the drug of choice. So this is how the hydrodissection is done.
Okay.
Sir, dextrose concentration is 5% or 10%?
5%. Okay. So now you see this nerve in the long axis. So first I'll be locating in the middle of the nerve. So middle of this. So again, this is the carpal tunnel. And I'm putting the nerve in the middle of and then what I'm doing, I'm just making the rotation. Okay, so হাতটা ভাঁজ কর ওটা কবজিটা ভাঁজ করতে বলছি হ্যাঁ বাবা ভুলে যাচ্ছিস তাহলে কবজিটা এইভাবে রাখবে এই আঙুল মুঠো করতে পারবেন এইভাবে রাখতে ওকে সো ইউ সি দিস ইজ one bone. What is that bone? Huh?
Scaphoid.
Distal end of the radius. Scaphoid will not come in the middle. I am holding the middle. So scaphoid will not be coming on the picture at all. I am holding the probe like this. You see, like this. Like this.
Cappuccino.
That is distal end of the radius. This is distal end of the radius. And this is one muscle in the cross section. What is that muscle?
Pronator quadratus.
Pronator quadratus. Okay. And then another bone. What is this?
Lunate.
Lunate.
Lunate. What is this?
This will be
Capitate.
capitate.
Very good. So remember, you draw a line from here. So carpal tunnel is this part. Means flexor retinaculum is this part, not the proximal part. Distal to this lunate and capitate junction. This draw and here this part. So what else you can see? This is the median now. And what you can see here, tendons, one tendons, another tendons. So flexor digitorum superficialis, flexor digitorum profundus, and median now. Three structures are seen very distinctly. You can see. So 1, 2, and just 3.
Right here.
Okay. See it again. Narasnahat. Okay. So can you appreciate? This is your distal end of the radius. This is a cross section of the pronator quadratus muscle. So this is the two tendons, and this is the nerve. And flexor reticulum is here. Okay, clear? So here also, what we do, this is the fenestration of the media of the flexor reticulum. In fact, we proudly say this, that we started the fenestration first in Daradia. So what we do here, it's like a surgical dissection. So this part above the nerve, this black part is your reticulum, black and white part. So what we do, we bring the needle like this, and we do the multiple puncture to over the reticulum to do the fenestration of the reticulum. So basically, we combine these two procedures together. One is we are doing the fenestration of the reticulum, and at the same time, we are doing the hydrodissection. The nerve must be floating. Nerve must float in dextrose water. So as I told you, please see the procedure video. So they'll be giving you a better idea. Okay, so this is about your carpal tunnel. I hope everybody has.
Can you just mark this, what I am seeing in the ultrasound image, sir?
And sir, and side,
Distal end
side
of radius, pronator quadratus,
What is this?
capitate,
What is
distal
this?
end of radius,
Okay, this is your
pronator quadratus.
in cross section. What
Yes,
is
sir.
it?
Capitate,
Lunate.
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 Lunate
That's
is
what.
proximal.
Okay.
This is your capitate.
Capitate,
Okay. And here
right.
this is the median nerve. This is the median nerve. And here there are two tendons, two rows of the two layers of the tendons. Flexor digitorum superficialis and profundus.
sir,
Okay.
what is
Sir,
the
just
what
here
will be the
the-
side for fenestration, sir? Once again, sir, the side in long axis.
Here, above the nerve. Take care that you are not puncturing the nerve. So this is the upper boundary of the nerve. So you just take care that you are not puncturing the nerve.
Sir, I've just shared the video in the chat box, sir, the carpal tunnel syndrome.
Okay, okay, very good. So you just go through that video. How to do the fenestration. Okay, fine. Can I go now to the first compartment? Or anybody wish to ask any questions regarding this? Okay, so now let me go to the first compartment. So what shall I do? I'll start from the listed tubercle. Listed tubercle will be dividing the which compartments?
Second and
Second compartment and third.
second
Third
and
compartment.
Okay, let me change my settings. Let me come to the wrist and hand. Okay, so I'm starting from here. And you search for this bony projection. Can you see like a pillar, like a mountain
Yes.
in the middle of my screen?
Yes.
So listed tubercle. So what will be this tendon? Third compartment tendon, and this is the second compartment tendon. Third compartment.
Pollicis longus.
What is this? It should start with
Extensor
and end with L. So what will be coming?
pollicis longus.
Extensor.
Pollicis longus. And here there are two tendons. Starts with E, ends with B, and starts with E and end with L. So
Extensor
Carpa
carpi
radialis longus,
and
extensor carpa radialis breve.
and here the second compartment tendon. This is third compartment tendon. This is the fourth compartment tendon together. Fourth compartment, remember what was there?
Extensor digitorum and extensor
extensor
indicis.
indicis.
So from this position, I'll be going towards the first. So here, again, this was the second compartment and the third compartment. And I am going to the medial side. Now you can see very nicely extensor carpi radialis longus and brevis. And then I am coming to the first compartment. So this is the first compartment. Okay. So you can see the two tendons there. So first one, this is your what? Starts with A.
Adductor
Adductor
pollicis
pollicis.
longus.
So APA. And what is this? Starts with E.
Extensor pollicis brevis.
Extensor pollicis, sorry, it will be ending with B, extensor pollicis brevis. So these are the two first compartment tendons. And what is this bone? Distal end of the radius. One thing you remember that I was here, if I am going more distally, this is the radial artery. And if I am going more distally, what will happen? Radial artery will be coming below the tendon. Can you appreciate that now? So if I'm going above, it is coming medially. Tendon is coming medially. Sorry, artery is coming medially. This is the artery. And if I am coming distally, then the artery is coming below the tendon. So this is not the tendons are very nicely seen here. Two tendons, abductor pollicis longus, extensor pollicis brevis. But that is not the area for the injection. Okay. So this bone is what? There's some bone is there. What bone is there? Between the first compartment tendon and radial artery. After that, what is that? What is that bone? What is tell from your common sense?
Scaffold.
Radial side starts with
Scaffold.
scaphoid. See, look too pretty. So see, and you can see the two first compartment tendon. But remember, that is not the area for the procedure. So your area of the procedure is where you are going to get the distal end of the radius. So here you can see the distal end of the radius. So this is the area for to do the procedure. So you will be doing the procedures in two ways. Number one is you give this, you can see this black and white line. So these are the tendons. And above that, you can appreciate this is your extensor reticulum. So your in the the decorpus disease that will be thickened and your needle should be coming here and giving injections in this plane. You can give steroid, PRP, but now still I personally prefer the steroid injection there. It is having the better evidences as well. So between these, and again, there are YouTube channel and recently in the Daradia Facebook fellows group also I have shared a decorpus procedure. So your needle should come like this and just above the tendon, between the tendon and the retinaculum, you have to give the injection. This is the short axis. And in the long axis, similar to that, is you can do the fenestration as well. So if you are seeing this is your first compartment tendons. So this is the distal end of the radius. This is the first compartment tendon. Tendon loops, hyperechoic fibrillar structures, remember. So here is your, this is your, the extensor retinaculum. So what you can do is your needle can come like this and do the multiple fenestration here. This black and white areas. So above the tendon. Be cautious that you are not injuring the tendon. But fortunately, during the decorpus disease, that extensor retinaculum will be thickened. And here it is very thin. That's why visualization is difficult. But in pathological slides, you'll be seeing that is thickened. And you can easily identify that. Still here it is, you can see this. This is your, this black and above that white area. That is your, sorry, that is your, the first compartment. So understood? I'm showing it again. So okay. So now it is even better seen. So this part is your extensor retinaculum. It extends like this. So do the multiple fenestration, puncture there in the long axis, and you combine the procedure there. Clear? This is your decorpus, first compartment. Right? Now A1 pulley. So what I'll do, I'm doing the aspect marker towards the lateral side. And you see, you can see the tendon. I'm keeping any of the tendons in the middle. Let me put this tendon. And I'm going, so the bone is metacarpal bone, right? And I'm going distally. See what is happening? Now the metacarpal bone is not seen. And now if I'm going still distally, so this is the phalangeal bone starts. So this is phalangeal bone. And just going proximally, no bone now. And now the metacarpal bone starts. So if I'm freezing it here, what you can see? This is the metacarpal bone, head of the metacarpus. After that, you can appreciate some black line. What is that black line? You can tell.
Articular cartilage.
Articular cut.
Articular cartilage of the metacarpal head. And after that, there is some hyperechoic structure, homogeneous hyperechoic structure. What is that? This is your articular cartilage, fibrocartilage. So this is your white fibrocartilage. This is your black, is your hyaline cartilage. So this is over the metacarpal head. This black and then white. So this white is what? Fibrocartilage. I told just now. Palmar plate. Palmar plate. Basically, this is your A1 pulley. A1 pulley is getting attached with the palmar plate. I have shown you in the 3D anatomy. And this part is your palmar plate. Hyaline cartilage. Below that black cartilage is your, the fibrous cartilage. Below that black line is your the articular cartilage. And then we are having the two tendons. This part is your flexor digitorum profundus, and this part is your flexor digitorum superficialis. So all this layer by layer, remember. First is your bony part. After that, black line is your hyaline cartilage, articular cartilage. After that, this is your palmar plate. That is your the fibrous cartilage. After that, this is your profundus, flexor digitorum profundus. After that, flexor digitorum superficialis. After that, this is your A1 pulley getting attached over here. Is it clear to everybody? Yes or no? Try to
Yes.
relate.
Yes.
Yes, sir.
Yes, sir. A1 pulley, please.
Yes. So now, how to inject? You have to inject. Normally, again, it will be thickened here. So you have to inject over this cleft between the white and the black area. This is the tendon and the A1 pulley. You have to inject. You can give the steroids. You can give the PRP. I personally prefer the steroid here. Okay. Now, in the long axis. In the long axis, what I can see here. Same thing I'll be seeing in the long axis. Okay. So you see, here this is your proximal phalangeal bone. This is your metacarpal head. And what is this black artifact?
Hyaline cartilage.
Hyaline cartilage.
Cartilage.
Very good. And what is this? White.
Fibrous cartilage.
What is the name?
Palmar plate.
Palmar plate. Very good. And after that, you can see the two tendons are running. Flexor digitorum. Deeper one is flexor digitorum
Profundus.
profundus. And that above that flexor digitorum.
Superficial.
And above that, if you are drawing a line from here. So A1 pulley is in this area. Means it starts from the line drawn from here and going little proximally, not distally. Okay. So exactly above the joint and little proximally. So this is this black, the hyperechoic areas is your A1 pulley. So what you can do is the long axis, you can come and you can do the fenestration there. So like in the median nerve, like in the decorvans. So here also you can do the multiple fenestrations in the long axis. Above this is the area, above the tendon, you do the multiple fenestration. That will be giving better results. I hope all of you understood the all by layer structures. Again, let me repeat. This is your bone. Then this black is your hyaline cartilage. After that, this is your fibrocartilage, that is palmar plate. After that, very nice two tendons. And this is your A1 pulley. Clear? Clear?
Yes.
Yes, sir.
Yes, sir.
Questions? So this much in the Sona anatomy today. Any questions or anything you wish to see again? No question?
Sir, extensor retinaculum just show once, sir.
Extensor retinaculum means Over the A1 pulley?
Requirements for, yes.
For the deeper ones. Okay, fine. In the long axis or in the short axis?
Short axis, sir.
Short axis, okay. Okay, I'm putting the probe directly over there. Normally, you should start from here, distal tubercle. And then you go, this is the second compartment tendons, 2 tendons. And then you come over here. So this is the first compartment, 2 tendons. You can see the 2 tendons. One is bigger, that is your abductor pollicis longus. One is shorter, that is your extensor pollicis brevis. And over that, you can see they appreciate some black areas, black lines. That is your extensor retinaculum. So this black line is your extensor, black and then upper height. So if you are giving steroid injection, your needle should come in this between the, just little above, between these black and white areas. In these areas, you have to give. And in the long axis, okay, so the distal end of the radius, above that, this is the tendon. So your retinaculum is here. Okay, clear? What is this bone?
Yes, sir.
What is this bone?
Scaphoid.
Scaphoid.
Very good. And there is some artery was pulsating. What is that artery?
Radial artery.
Radial artery. Very good. Okay, so this much from my side. And now other speakers are waiting. So Shruti, are you there?
Yes, sir, I'm there.
Okay, I'm stopping sharing and you can share your slide. And Siris, are you there? I'll be making you host.
Yes,
Siris?
sir. I'm here, sir.
Okay. And good night to all of you. I have to leave, as I told you. I have to catch flight. I have to run to the airport now. So I'm making Siris host. And they all will be taking care. So thank you very much.
Good night, sir. Happy journey, sir.
Safe journey.
Thank you, sir.
Thank you,
Right, sir.
Good night.
Sir, my slides are visible now, and
Yes, your sound is audible. Slides are visible. Make it full screen, Dr. Smith. Yes, now it's great.
thank you so much, sir. Okay. Yes. Good evening, everyone. Today, the one of the most important class is your examination and history. These are the 2 important part, and this is essential to identify the underlying cause and guiding appropriate treatment. So here we will discuss the clinical examination steps, and those are essential for evaluating the elbow and wrist pain. And here we will discuss one by one. So to start with, we will start from the history itself. So the history is the most important starting point. And when you find any patient of elbow pain or wrist pain in your OPD, then start with the history. A detailed history helps to identify the nature, onset, and pattern of the pain, as well as any previous injuries or conditions. And when you start asking about the pathology, you just start with the ask about the patient symptoms like location, where exactly it is localized, and intensity, that we, intensity of pain we assess with the numerical rating scale, verbal rating scale. So you assess the intensity, then duration, for how long he has or been suffering from the pain, and what is the type of pain, whether it is nociceptive or neuropathic type of pain, and whether there is any trauma history or any fall or any sports injury, because elbow and wrist injuries are very common with sports person. And remember, one thing you need to ask about the red flags. If there is any red flag like any trauma, any fracture, okay, then any associated symptoms like tingling, progressive weakness, that it may indicate any nerve involvement. And there is always ask about this question. Then briefly, in brief, what examination you should follow next is the examination And first of all, inspection, look at the patient as a whole. And the general signs like signs of inflammation, deformities, or any changes of posture can provide the clue about any other systemic conditions, because rheumatoid arthritis, the most common part is affected is wrist and elbow. So what else we need to observe? That other signs like muscle atrophy, any swelling or any deformity in both the wrist and elbow areas. And before focusing on elbow or wrist, first focus on overall physical condition. Look for any sign of systemic disease that could affect the musculoskeletal system. Then we will go to the inspection, and visual inspection is essential because it is used to detect the visible signs, what like swelling, bruising, any deformity, any asymmetry, or any change of posture. And always check for any joint deformity in the finger or any skin changes or any signs of trauma like bruising. And also compare it with the normal side or other side, whether it both side looking same or different, like skin tone, any changes that you need to inspect. Then on palpation, it it allows you detection of the tenderness and temperature changes and swelling in specific areas around the joint. It also helps to assess the condition of ligaments, tendons, and bony structures. And what to palpate? Always try to palpate the bony landmarks, like for common extension tendon or tennis elbow, we always palpate the lateral epicondyle. For golfer's elbow, we always palpate the medial epicondyle. Similar way, for triceps tendinitis, we always palpate near the olecranon. So remember the bony landmark and palpate accordingly. And also for any joint, always try to evaluate tenderness over the joint lines, medial and lateral joint lines. And also its ligament attachment site and muscle group. And palpation is crucial for identifying the localized tenderness, swelling, warmth, and any fracture. Then range of motion. In brief, I will discuss about the range of motion because later we will discuss individual range of motion. Here we have to identify the mechanical issues, any muscle weakness, any joint stiffness. Both active and passive range should be assessed. And here you need to test both flexion, extension, pronation, supination at the elbow and wrist. And you should note whether there is any restriction, whether there is any pain. And always you should remember, while assessing the range of motion, assess both active and passive range of motion in the elbow and the wrist. And a limited range of motion or pain during movement help you to identify the cause. Then next is neurological examination. Elbow and wrist pain may have neurological components, especially if there is nerve impingement or entrapment. This step evaluates sensory, motor, and reflex. So there are, you must be knowing about the reflexes and sensory motor. So here, sensory changes, any tingling, numbness, you need to check any motor strength like grip strength, finger dexterity, and reflexes. So there are three important nerves in this area like ulnar nerve, median nerve, and radial nerve. So perform neurological examination to assess the signs of nerve involvement also, like sensory deficit or motor weakness that may indicate any compression neuropathy or entrapment neuropathy like carpal tunnel syndrome, cubital tunnel syndrome, or radial tunnel syndrome. So there are few special tests are there which helps to confirm the specific conditions. There are many tests we will discuss later, and they are more focused on particular diagnosis. So that's why they are called special tests. So we will discuss this one by one. So this examination is very important. So we have here in the history, we have already discussed that location, intensity, quality, radiation. In brief, again, we will conclude what are the things we need to remember during history and examination. So I'm repeating again that location, intensity, quality, radiation, aggravating factors, and relieving factors, and you need to check pain in any other sites. Any associated symptoms, morning stiffness, night pain, important for inflammatory arthropathy, muscle weakness, any neuropathic pain or grip strength, that is radiculopathy, associated systemic complaints and comorbidities like other conditions, like if there is any fibromyalgia or any inflammatory arthropathy or diabetes, it we need to correlate. And in the past history, you need to remember that if there is any history of trauma, any injury, surgery, or CRPS, and history of diabetes, history of hypothyroidism, fibromyalgia, obesity, inflammatory arthropathy, these are few important histories that we need to ask. And personal history, is there any history of smoking, alcohol intake, drug abuse may lead to degenerative arthropathy. Occupational history, why it is important? Because most of these cases are due to repetitive microtrauma or repetitive activities. And physical examination, we have already discussed. Inspection, again, we need to check any swelling, any redness, any deformity, any degenerative changes, or atrophy of muscles or skin changes. And on palpation, again, crepitus, swelling, tenderness, effusion that we need to palpate. We can feel the crepitus, we can feel the swelling or tenderness. And these are few red flags that we have discussed: infection, fracture, any compartment syndrome, any motor weakness due to various nerve and muscle disorder, or progressive sensory deficit that we need to evaluate. And range of motion, again here the important we need to remember the range of motion, extension of the wrist. So wrist at the wrist normal extension is up to 75 degrees. And how you do that? Ask the patient to maximally extend or dorsiflex the wrist, and it is up to 75 degrees. Flexion, ask the patient to flex the wrist, and a normal person can flex up to 80 degrees. Adduction means ask the patient to maximally adduct the wrist. Normal adduction means towards medial side, adduction. And abduction means opposite side, lateral side. So these are few special tests for the wrist. And here we will start with the Finkelstein test, and you must have heard about the de Quervain's tenosynovitis. And this is specific diagnostic tests for specific cause, like de Quervain's tenosynovitis. So here this is how we perform the Finkelstein's test. First, you need to stabilize the patient, and then you need ask the patient to stabilize the patient forearm, having the patient fully flex the thumb into the palm. And here in the picture, you see the patient has placed their thumb inside their palm and enclosing the thumb with other fingers like this. And then what examiners will do exactly here, he or she will, you will be stabilize here the examiner's one hand has stabilized the patient's elbow or forearm, and he or she will gently deviate the wrist towards the ulnar side. Okay, ulnar side like this. And we have the first compartment or de Quervain's tenosynovitis in the radial side. So when we are doing ulnar deviation, means opposite to the radial side, there will be, if there is de Quervain's tenosynovitis, the patient will experience a sudden severe pain and along the radial side of the wrist. And what happens in de Quervain's, as sir demonstrated, the first compartment, the abductor pollicis longus and extensor pollicis brevis tendon inflammation leads to de Quervain's tenosynovitis. So here, why it is important? Because the earlier you diagnose, earlier you can treat. And early treatment includes RICE protocol and NSAIDs. Later, if it is not resolved, then you can go for a steroid injection. Then come to Tinel sign. Tinel sign, what is Tinel sign? Here you can see there is a hammer in the examiner's hand. So it must be a diagnostic test for carpal tunnel syndrome or any compressive neuropathy. So what will we do here? Ask the patient to position their palm upwards. That is, the hand of the patient is in supination. So dorsiflex the affected hand to increase the tension over the carpal tunnel and flexure retinaculum. So here we have to create maximum pressure in the flexure retinaculum. So what we will do, examiners will again stabilize the forearm in one hand, and another hand he will have a broad side of the hammer, like you can see this hammer, and this is the broader side and this is the narrower side. So through the broader side you need to percuss gently over the medial nerve at the wrist. So if the patient experience a tingling or paresthesia in the thumb, index and middle finger, these three finger, remember, thumb, index and middle finger, then the test is positive, not in the little finger and ring finger. Okay, remember these two finger is for ulnar nerve entrapment, these three for median nerve at carpal tunnel or carpal tunnel syndrome. So suggest that medial nerve irritation or there is an entrapment at the carpal tunnel. So this test distinguishes carpal tunnel syndrome from Guyon's canal syndrome. So it is very useful test. So we need to remember. Then coming to the Phalen's test. And here examiner has no role. Ask the patient to flex both the wrist to the maximum palmar flexion as shown in the picture and without applying any force. So the wrist should be kept in this position for 30 seconds. And a positive test means if the patient experience paresthesia, numbness or pain again in the thumb, index finger and middle finger, that means along the distribution of the median nerve, then this test is positive. Again, this is another specific test for carpal tunnel syndrome. Then coming to the spread sign. So what, see spread sign where it is seen between the little finger and ring finger. So what could be the pathology? There must be ulnar nerve involvement. And for assessing ulnar nerve dysfunction, particularly the intrinsic weakness in the hand. So how it is performed? Here the patient is asked to spread or abduct the fingers apart as far as possible while keeping the hand relaxed on the examination table. So a positive test means when patient is unable to abduct two or more fingers properly. And why this happened, you know, ulnar nerve supplies the dorsal interosseous muscles that are responsible for finger abduction and which are innervated by ulnar nerve. So due to weakness of the dorsal interossi, there is lacking of this spread sign is positive. And if ulnar nerve is compressed or damaged, then these muscles become weak and that lead to inability to spread the fingers apart. And next test is Duncan's test. Duncan's test is another test for diagnosis of carpal tunnel syndrome. Here again, this is a very simple test. Here you need to apply a firm pressure over the carpal tunnel region where near the base of the palm and maintain that pressure. See the examiner held the hand of the patient at the base of the palm and he has put a pressure and you need to keep that pressure for 30 seconds. And if the patient experience again the same pain, tingling, numbness in the thumb, index and middle finger or radial half of the ring finger, that means median nerve compression is carpal tunnel is positive. Then evaluation of elbow, again we will discuss few more points here on inspection, angle of the elbow. So remember, if there is a normal carrying angle of the elbow, that is 10 to 15 degree in males and 15 to 20 degree in female. So what do we call the increased carrying angle? That is the cubitus valgus. And increased what does it mean, that cubitus valgus? If there is an increased carrying angle in the elbow, that means that suggests yes, earlier patient was normal, but later there is an increased carrying angle. That means there is a chances of ligament injury. And which ligament? Ulnar collateral ligament tear or any supracondylar fracture in the childhood. Those people you will find cubitus valgus. And what is the meaning of cubitus varus? There is decreased carrying angle. So, or there will be their elbow will remain in slight flexed position. So this happens when there is malunited supracondylar fracture of the humerus, or there may be infection, inflammation, or any trauma earlier. So then
Ma'am,
any
can you please
swelling.
repeat this cubitus valgus and varus of elbow?
Okay, so normal carrying angle of the elbow is 10 to 15 degree in males and 15 to 20 degree in females. Okay. So if there is an increase in the carrying angle, that means if it is more than 20 degree or more than 15 degree, that suggests any ligament injury. Which ligament? Ulnar collateral ligament, or any fracture malunion during childhood, like supracondylar fracture of the humerus. And if there is decreased angle, then decreased carrying angle of the elbow is known as cubitus varus. So this is common, usually common in any infection like rheumatoid arthritis or inflammatory arthropathy, or any again fracture, supracondylar fracture of the humerus may lead to both cubitus varus and valgus deformity. But for us, that is not important. For us, it is important to identify the inflammatory arthropathy and any ligament injury. Okay. Are you clear, Dr. Amukta?
Yes. Thank you,
Okay.
ma'am.
Welcome.
I
So,
wanted you to show the carrying angle, if possible, how you will see the cubitus varus and how you will see cubitus
okay,
valgus.
picture is not right there.
Yes.
Okay. Okay, I will send it later.
No problem.
Then next, okay. Then swelling or redness. Okay, swelling or redness, that means there is some acute inflammation or infection or trauma, or any olecranon swelling, because olecranon bursitis is common during repetitive trauma or infection. And check for any nodules, because nodules are very common in rheumatoid arthritis or gout or other systemic condition. Then coming to palpation, a palpation is very important in this case, because most of the diagnosis in the elbow and wrist we have seen many special tests with palpation, and here also. So one by one, how we start palpating? Palpate from the antecubital fossa. Okay, antecubital fossa. If you are palpating or putting pressure over the antecubital fossa, that may suggest and there is tenderness, then what will you think? First thing that comes to our mind is biceps tendon rupture or any brachial artery injury, or biceps tendinopathy, also distal biceps tendon tendinopathy. And if any swelling is there in the antecubital fossa, then you may think of any bursitis, any hematoma, or any DVT. Or if there is any pulsation, then you have to check the integrity, send them to radiologist for an ultrasound. Then lateral epicondyle. Lateral epicondyle, if there is a tenderness, then that suggests the tennis elbow, as you know. And if there is swelling, remember tenderness may suggest tennis elbow. But if there is any swelling, then you can think of radial collateral ligament injury, or there is any osteophyte formation due to degenerative arthritis of the elbow. So that you need to remember. And medial epicondyle, if there is any tenderness at the medial epicondyle, then it suggests golfer's elbow. But if any swelling is there, then you consider rheumatoid arthritis or ulnar nerve entrapment or cubital tunnel syndrome. Then posterior elbow. Posterior elbow swelling, all of you can easily diagnose olecranon bursitis or rheumatoid arthritis nodule or gouty tophi. Okay, tenderness, if there is any tenderness again at the olecranon, then think of triceps tendinitis or olecranon fracture. Then coming to distal end of radius or ulna, then if there is any tenderness at distal end of radius, then think of fracture. Okay, we know that these are not our part like Aliazi or Monteggia fracture. These are orthopedic case. And then crepitus, if there is any crepitus, think of degenerative arthritis or any post-traumatic arthritis. Then these are the range of motions of the elbow that we have discussed. Flexion of the elbow normally ranges from 0 to 140 to 150 degree. And the main muscle for flexion, we know the elbow flexors are biceps brachii, brachialis, and brachioradialis. These are the three key muscles that keep the elbow flexing up to maximum 140 to 150 degree. And if there is any restricted flexion, then what you should think of, consider it biceps tendon rupture or any joint effusion or any fracture. And extension means straightening of the elbow. Straightening of the elbow, normal range is 0, but it can be hyperextended. 5 to 10 degree hyperextension is normal. We consider it as normal. And key muscles of extension are triceps brachii, anconeus, and the most important is triceps. Don't remember other small muscles. Then coming to pronation. Pronation means you are giving blessing to someone. Okay, blessing to someone. Then pronation, that is the palm down. And normal range is 0 to 75 to 85 degree. But here the key muscle is pronator teres and pronator quadratus. And if there is any pain or restriction of movement, then think of any fracture. Or one important diagnosis here, you to check if there is any restriction or pain during pronation is triangular fibrocartilage damage, TFCC injury. It is an important sign. And another is pronator syndrome. Okay, and supination, normal range of motion is supination. Supination means you are begging to someone, or elbow supination, palms up. So normal range is 0 to 80 to 90 degree. And key muscles are supinator, biceps brachii. If there is limited supination, then consider radial head dislocation or biceps tendon injury or forearm fracture. Then there are two tests. One is varus stress test, another is valgus stress test. So varus stress test is used to assess the lateral collateral ligament injury, and varus stress test is used for medial collateral ligament injury. And you see how they are performed. So first, patient position. Again, shoulder is abducted. See, it is abducted up to 75 to 80 degree, and elbow is flexed to 30 degree. So remember the shoulder abduction and elbow flexion, first position. Then this is the position. In this position, we test both valgus and varus stress. And valgus stress, you need to remember that standing position, shoulder, it's an examiner, you apply the pressure or stress from medial to lateral side of the elbow. So, and this is the second picture is the varus stress test. They are putting pressure towards the medial to lateral. And if it is positive, then indicate lateral collateral ligament injury. And valgus stress test, again, it applies the pressure from lateral to medial. And this is positive in MCL injury. Then these are few special tests for wrist. Froment sign is used specially for ulnar nerve dysfunction. And here we need to assess the ulnar nerve. So here, first position of the patient, you ask the patient to grasp a piece of paper between the thumb and index finger in a pinch grip. Okay, pinch of salt, like how we keep it, like that. You ask the patient to hold the piece of paper and you check the angle. See, the normal angle of the thumb is like this. But in comment sign, there will be an increase in angulation of the thumb. Okay, so that means you will notice an increased deformity or flexion deformity of the thumb at the interphalangeal joint. Due to why it happens? Because flexor pollicis longus muscle that is supplied by the median nerve is compensated, and weakness occurs in this muscle. So why? Because the adductor pollicis ulnar nerve is weak and non-functional. Okay, so this muscles, flexor pollicis muscle, compensates the weakness of the adductor pollicis muscle supplied by ulnar nerve. Then tennis elbow test. And one more important thing here, if another thing you remember in the froment sign, if the metacarpophalangeal joint of the thumb also extended, hyperextended, then you think of additional weakness of first dorsal interossi also. Again, that is supplied by ulnar nerve. Then come to tennis elbow test. Tennis elbow test, also known as Cosen's test. And here it is mainly used to diagnose, all of you know that diagnose for the tennis elbow or common extensor tendinitis or tendinopathy. Here again, the patient's forearm is stabilized by the examiner, and the patient first, you see, they have clenched their fist and actively extend the wrist. And here examiner will apply a resistant trying to force the wrist into flexion. Okay, and sudden severe pain over the lateral epicondyle suggests that it is tennis elbow. And remember one thing, tennis elbow is a maybe it is a misnomer. It may be due to common extensor tendinopathy is mainly due to repetitive microtrauma, and it's a degenerative tendinopathy over inflammatory. Inflammation, it may last for 7-8 days, and you can it got easily treated with any NSAIDs or rest, ice compression, but tendinopathy doesn't. And here it is the main muscles, those main tendon of the two muscles, that is extensor carpi radialis brevis, is involved due to repetitive microtrauma. And golfer's elbow test, here this is for test for medial epicondylitis, and here used to again the same, everything same. The examiner stabilizes the forearm, patient actively flexes the wrist. These are the everything is step, except the examiner here apply the pressure in the opposite direction, that is trying to force the wrist into extension. Okay, and if it is positive, if the patient is having sudden severe pain in the medial epicondyle, then it is sign of common flexure tendinopathy. And here it is mainly due to here two major muscles and two most common muscles involved in the flexor, the medial epicondylitis are flexor carpi radialis and pronator teres muscle. And okay, that's all for today. If you have any doubt in the history, general examination, and special test, range of motion, then you can ask. I can show you the slide.
Excuse me, ma'am.
Yes.
About the misnomer, what will be the perfect term that it is lateral epicondylopathy?
Yes, that is the nowadays we can say common extensor tendinopathy.
So lateral epicondylitis or medial epicondylitis is not.
Yes, you can, but tennis elbow and golfer's elbow are no more used. I mean, rarely used.
Okay, thank you.
Welcome. Any other doubt or
Thank you, Smriti, for a detailed and wonderful presentation. I'm sure you have compiled lots of book to prepare this PowerPoint. Very excellent.
Thank you, sir.
For the wonderful class.
Thank you so much, sir. So I'm stopping the sharing of my screen. Sirius, sir, over to you.
Yes, I think the next speaker is Dr. Wayne, no? Vidyana. Good evening, Dr. Vidyana.
Hey, good
Please share the
evening,
slide.
Dr. Yes. Yeah, thank you, thank you. Can I share my slide first?
Yes, yes.
Yes, can you see this my slide?
Not yet, sir. Yes, yes, we can see now. Very nicely.
Yes, sir.
Thank
Now we
you.
can see.
First, I would like to thank Dr. Smriti Hota to inviting me and give me the task about presenting of tennis elbow and golf for elbow, diagnosis and the management. Yeah, I studied in Daradia pain clinic on 2012. Yes, thank you for inviting me. Yeah, let me
Thank you,
start
sir.
with the title of tennis elbow and golf for elbow, the diagnosis and the management. Yeah. As explained by Dr. Smriti Hota before, that the etiology of tennis elbow is an overuse injury, primarily due to repetitive strain from activity that involve loaded and repeated gripping or wrist extension like that. Yeah. From historically occur from any sport that require repetitive wrist extension, radial deviation or forearm supination. Yeah. Sometimes it's precipitated by poor mechanic or technique or improper equipment in the athlete patient population like that. Yeah. The clinical sign of the tennis elbow is pain with the characteristic of the pain is sharp pain, burning pain, throbbing pain at the lateral side of the elbow with motion with gripping, lifting, or extending of the wrist. Yeah. Sometimes it's tenderness over the lateral epicondyle and weakness like difficulty in gripping an object or turning doorknob or shaking hand. Yeah. Sometimes a patient swelling in the lateral epicondyle and limited range of motion. Yeah. Pain can restrict elbow flexion and extension like that. Yeah. And this is the histopathology. From histopathologic examination of the extensor carpi radialis brevis specimen, the characteristic is hypertrophic and or abundant fibroblasts, collagen disorganization, vascular hypoplasia, but sometimes lack of inflammatory cell in the examination like this. Yeah, from the history is pain with an insidious onset over lateral elbow, worsen with activity and improve with rest like that. Yeah, and often relate to an overuse history without a specific insinuating traumatic event. Yeah, pain commonly occur 1 or 3 days after unaccustomed activity that involve repeated wrist extension. Yeah. Sometimes history is from new equipment use or atypical workout circumstance such as abnormally intense or prolonged workout in athletic. Yeah. This is very important. Sometimes it's precipitated by acute injury or strain, such as lifting unhappy object like that. Yeah. This is the pathologic stick of the lateral epicondylitis. Yeah, there is a 4 stick. The first stick is peritendous inflammation with no pathologic alteration, and the stick 2 is with pathologic alteration such as tendinosis or angiofibroblastic degeneration, and stick 3 is pathologic changes and complete structure failure like that. Yeah. And the stick 4 is involving fibrosis, submetric calcification, or hard osseous calcification, and addition to a feature of stick 2 and stick 3. And this is the clinical classification of lateral epicondylitis. Like there is 7 phase. Yeah, phase 1 with mild fine after activity, usually recover within 24 hours, and the P7 is consistent pain at rest, aggravated after activity, and sometimes disturb sleep like that. Yeah. Okay. On physical examination is very important how to diagnosis of the lateral epicondylitis, like palpating in the lateral epicondylitis. There is any pain, tenderness, or swelling. And the second test, you can do a coffee cup test like that. Yeah, check for pain while grabbing a cup of coffee or any object like this. Yeah, this motion is engage the forearm muscle and load the tendon that attach your lateral epicondylitis like this. Yeah. Okay, and then you can do a dynamometer grip strength test. Yeah, by squeeze the dynamometer as hard as you can. Repeat it 2 or more time, and usually the normal grip strength test is 40 until 50 kilogram for male adult, or for female usually around 25 until 30 kilogram like that. Yeah, you can squeeze the dynamometer 2 or more time. And then this is the resistance test. Resistance test is two kinds, as palm and finger resistance test. Yeah, this is the technique how to do the resistance test for palm. Straight your elbow and raise and extend your wrist and give a pressure like that. Yeah, and this action is engage the muscle that flex your wrist and attack your lateral elbow. This is if the tennis elbow is present, patient will feel pain. Yeah, and this is the grip. This is the extending middle finger test, or what we call Maudsley test. Yeah, this action will test the extensor digitorum attached to lateral epicondyle. You can do the other test is like chair pick up test. Yeah, this is the action of chair pick up test. In this test, we need a typical wood or a metal chair. Make sure it's a light less than 22.5 kilogram. Yeah. Try to pick up the chair with just a thumb, pointer finger, and middle finger. Yeah, with your arm extended and palm down, grab the back of the chair. Yeah, with just the 3 digit, try to lift it off the ground. Yeah, if you have a tennis elbow, you will feel pain in the lateral epicondylitis. Yeah. And the pipe test is maybe you can do a mild test. Yeah, the mild test you can do like that. You flex the elbow and pronate the forearm and flex the wrist. Yeah, and then you palpate the lateral epicondyle. Yeah, like this. Yeah. Okay, the cushion test you can do a cushion test. Yeah, put the forearm in the table like that, flex the elbow, and then palpate the lateral epicondyle, and you extend the wrist. Yeah, extend the wrist with a pressure like that. Yeah, if you have a tennis elbow, you will feel pain in the lateral epicondylitis. Yeah, you can do a poke test too. Yeah, like this, just flex the elbow and then extension of the wrist. Yeah, or you bring some book like this, less than 2.5 kilogram, and then feel the pain in the lateral epicondyle. If you suffer or getting a tennis elbow, you will pain in the lateral epicondyle. Yeah, an evaluation. Yeah, evaluation of the lateral epicondylitis is a clinical diagnosis, and imaging study it often not necessary. Yeah, just consider radiographic series if the condition you suspected, like degenerative joint changes, fracture, tumor, or bursitis, or if treatment of the non-operative treatment is not reduce the pain, maybe you consider MRI or ultrasound evaluation to see for tear, stress fracture, or osteochondral reflex like that. Yeah. This is some differential diagnosis of the lateral epicondylis, like elbow bursitis, cervical radiculopathy, posterolateral elbow plica, radial tunnel syndrome, ankle fracture, capitular osteochondritis dissecans, tricep tendinitis, or radiocapitular osteoarthritis. The treatment goal is controlling the elbow pain, preserving movement of the affected limb, improving grip strength and endurance, restoring normal function of the affected limb, and preventing further deterioration. Non-operative treatment is always the first of choice, like activity modification. Modification of activity and avoidance of the overwork. This is very important. And tuning palm up while lifting or avoiding palm down exercise. Like this. Patient should be advised to correct advanced lifting habit and stay away from some inside-knitting activity. The principle of rise is very important. Rest, ice, compression, and elevation can relieve the pain. Okay, this is the rest, ice, compression, and elevation. And you can do a physiotherapy. Physiotherapy, electrotherapeutic, and non-electrotherapeutic modality, aiming for improving function and reducing pain by stretching or strengthening the affected rise extensor. And you can do exercise eccentric via stretching or of the musculotendinous unit and with an applied load. Okay, you can do, you can give the patient of anti-inflammatory medication like oral non-steroid anti-inflammation, or you can do topical non-steroid anti-inflammatory medication. Sometimes we need a corticosteroid injection, peritendon. Don't inject the steroid around inside the tendon because dangerous, because if you inject the steroid intratendon, this is maybe can result in iatrogenic tendon rupture like that. Just if you use injection of steroid, just a peritendon. Maybe you can use counter force brace too. The counter brace is like this. You can use this bracing to minimize the this counter force brace can significantly elevate the pain by pressing on the forearm extensor muscle and then inhibiting and dispersing the stress on the origin of the affected extensor carpi radialis brevis. This counter force brace can significantly decrease the frequency and severity of pain for 2 until 12 weeks and improve the elbow function at 26 week. Like this. This is a rise extension orthosis. You can do this too to manage. And this is the extracorporeal shock wave therapy. But the mechanism of the extracorporeal shock wave therapy is not been completely clarified, but possible by including direct stimulation on the healing, neurovascularization, direct suppressive effect on nociceptor, or hyperstimulation mechanism by blocking the gate control. This electrocorporeal shock wave therapy is recommended if the symptom persists for more than 6 months. This is how to set the electro shock wave therapy. Some study use frequency. The frequency is 10 until 15 Hz like this. The energy level is 18 kilovolt. This is the, if you want to do treatment with electrowave shock therapy, you must set like this. Okay. You can use to autologous blood injection. Drawn your own blood, maybe 3 until 4 cc, and then inject in the tendon lateral epicondyle. Okay, as Dr. Gautam Das said before, that platelet-rich plasma injection. You can use a platelet-rich plasma. The platelet is releasing high concentration of platelet-derived growth factor, so enhancing bone healing and tendon healing. Yeah. Okay, the prognosis of tennis elbow is generally good. Most patients have a pain relief within 12 months of conservative treatment. Yeah. Okay, we continue with the golf elbow. Yeah. We know at the golf elbow is tendinopathy of the medial common flexor tendon of the elbow due to overload or overuse. Yeah, the tendon is approximately 3 centimeter long, cross medial ulno-humeral joint, and run parallel with the ulnar collateral ligament. Yeah. Okay, this is the relevant anatomy as pronator teres, like Dr. Smruti Hota said before. Flexor carpi radialis brevis, palmaris lumus, flexor digitorum superficialis, and flexor carpi ulnaris. But the pronator teres and flexor carpi radialis is the common affected. Yeah. The clinical presentation is pain in the medial elbow. Yeah, proximal forearm pain with activity requiring waist flexion extension. Yeah, usually seen in the age of 35 until 55. Yeah, like that. Yeah, the etiology I think is the same with lateral epicondylosis or tennis elbow. Is seen in athletes who are involved in sport that require repetitive valgus or flexion at the elbow, like in the tennis player, golf, swimmer, or fisher, like that. Yeah. The pathophysiology is the medial epicondyle is condylitis is overuse tendinopathy due to chronic repetitive concentric or eccentric loading of the wrist flexor. Yeah. Repetitive activity lead to recurrent micro tear within the tendon and subsequent tendinosis. Yeah. The pronator and flexor carpi radialis is a bit more common affected. Yeah. From the history, usually as an acute, a patient is have an history of acute traumatic blow or repetitive blow, like a gripping or vagus stress. Yeah. Sometimes patient feel itching pain on the medial or ulnar side of the elbow, yeah, radiating from the epicondyle down into the forearm and oris. Yeah. And pain is worse with forearm motion, gripping, or throwing. Yeah. Sometimes if pain resolved with cessation of the activity. Yeah. Yeah. Patient also feel stiffness, weakness, numbness, or tingling. Yeah, like that. Okay. The pathologic state is there is two pathologic state, yeah, tendinopathy and structural breakdown. Yeah. Tendinopathy, repetitive strain can cause tendon to degenerate. Yeah. Structural breakdown. This is the stick. If the issue isn't addressed, the tendon can break down structurally and resulting gradual worsen of the symptom. Yeah. From physical examination, sometimes the doctor find a swelling, erythema, or worm in acute case. Yeah. Tenderness over the pipe, weak is normal. Yeah, like that. On physical examination is this is active physical examination or passive. Yeah. In the active, yeah, patient raises wrist flexion, but in the passive component, the patient stand with the arm resting on the table and palm up, pick the patient and humerus, then passive extend the patient wrist and forearm like this. Yeah. Okay, this is the active wrist flexion again resistant. And then another test you can do is a reverse caution test. Yeah. Also diagnostic with ultrasound and POC test. Yeah. Reverse caution test, flag the elbow and flag the wrist, and then give a pressure like that. Yeah. And then ulnar deviation. Yeah. Okay. This is the reverse caution test. This is the POC elbow of the medial epicondyle. And this is some differential diagnosis like neuropathy, intra-articular issue like adhesive capsulitis, arthropibrosis, or loose body, medial epicondylar fusion fracture, myofascial difficulty including flexor or pronator strain, sometimes valgus extension overload or synovitis. Yeah. The treatment I think is the same with the lateral epicondylitis or tennis elbow is conservative treatment is very important, I think. Yeah. with the cessation of the offending activity, including decreasing the volume, frequency, and intensity. Sometimes we can use a non-steroid anti-inflammatory drug or acetaminophen, physical therapy, extracorporeal shock wave therapy, electrical stimulation. Sometimes we need a corticosteroid injection, but there is just a short-term benefit, no long-term and medium benefit for corticosteroid. Maybe the choice of injection is maybe platelet-rich plasma, Okay, the prognosis is favorable, and most patients can return to work or sport after completing the physical therapy and activity modification. Thank you, and that's all my presentation. And for the time, we give back to the moderator. Thank you, Doctor. That's all my presentation. Maybe any question or?
Thank you, Dr. Vidana, for a very nice presentation. Really loved your presentation. Thank you very much. So if there is any questions, a few questions for Dr. Vidana regarding golfer's elbow and tennis elbow. If there is any question, please, just few questions.
Please.
What are the tendons involved for tennis elbow, doctor?
What the tendon?
Yes.
So
the tendon.
what are the tendons involved in tennis elbow, sir?
In the tennis elbow, there is a extensor tendon, especially for extensor carpi radialis brevis, especially for carpi radialis brevis, because extensor carpi radialis longus does not attach in the lateral epicondylitis, Sometimes extensor carpi ulnaris, extensor digiti minimi, extensor digitorum, but the most important affected in the lateral epicondylitis tennis elbow is extensor carpi radialis brevis,
Thank you, doctor.
The target is extensor carpi radialis brevis, but sometimes extensor carpi ulnaris, extensor digiti minimi, extensor digitorum, something affected too, but most important is extensor carpi radialis brevis. Thank you, doctor.
Thank you, sir. Any more questions before we go to Dr. Mazhar?
Please stop the share. Stop sharing, please.
Okay.
Thank you.
So the next topic, thank you, Dr. Vidana. A very nice presentation.
Thank you
very much. So next presentation is by Dr. Mazhar. He's a very good friend of mine. He's from Bangladesh. He's a very upcoming new and energetic pain physician of Bangladesh. Okay, so we usually call him as junior Dr. Kausar Sardar. So he is a junior Dr. Kausar Sardar from Bangladesh, and he's talking regarding very nice topic and very important topic, that is decubitus stenosynovitis, as well as he'll be also talking about this trigger finger. And carpal tunnel syndrome, of course. So I've shared a video of carpal tunnel syndrome, and you'll be also sharing his videos regarding all three procedures. Okay. Thank you. Dr. Mazhar, please continue.
Thank you. Thank
Hello?
you, Doctor. Am I audible?
Yes, you are audible, and the slide is full screen.
Okay. Thank you, Dr. Shirish and Dr. Shruti and other faculties. And my video is not.
Your slides are visible. Can you just increase your volume, Dr. Mazhar?
Yeah. Thank you. So Ramadan Mubarak to all. And it's time for Tarabi in my country. So Myself, Dr. Majhar. I'm working at Pain Clinic, Bangladesh Korea Friendship Hospital, Dhaka, Bangladesh, as a pain specialist. And my big identity is I'm a 1-year Daradia fellow. So let's get started. Today I'll talk on carpal tunnel syndrome and decoherent stenosynovitis. But Shiri told about also trigger finger, but this is not my today's topic. My today's topic, carpal tunnel syndrome and decoherent stenosynovitis. So can I start, Shirish?
Yes, sir. Yes, sir. Please start, sir.
Thank you. So, you know, the carpal tunnel syndrome is the most common peripheral nerve entrapment syndrome. And the symptoms include numbness in the hand at night, pain, weakness, feeling that hand is swollen, and sensation is decreased in the volar aspect of the thumb, index, middle, and radial half of ring finger. And gold standard for diagnosis remains nerve conduction studies and electromyography, but ultrasound criteria for carpal tunnel syndrome have been developed. So today, I'm trying to highlight about anatomy, risk factor, and causes, diagnosis, and how you can diagnose in ultrasound, that is ultrasound features for carpal tunnel syndrome also, and finally management product. So this is very shortly, I'm going about anatomy. So anatomy, everybody you know, and Das sir already has told a lot of things. So here you can see the picture. This is a carpal tunnel, which floor is formed by carpal bone. And everybody you know, there are 8 carpal bone. And one mnemonic says, "She looks too pretty, try to catch her." So the floor is formed by carpal bone and roof is formed by transverse carpal ligament that is called flexoretinaculum. And you have to know in the wrist, there are 3 ligaments. That is, one is transverse carpal ligament that is called flexoretinaculum. Another is volar or plumbar carpal ligament that is roof that contain the roof of Gans canal. And another is dorsal wrist that is called extensor retinaculum and or that is dorsal carpal ligament. So 3 ligament is available in the. So here, this picture also shows inside the tunnel and outside the tunnel. And this is there are 3 tendons outside the tunnel, and ulnar nerve artery and radial artery is outside that. And inside the tunnel, there are 9 tendons. One is flexor pollicis longus, and other 8 are flexor digitorum superficialis and flexor digitorum profundus, and definitely median nerve inside the tunnel. So tunnel lateral boundary, that is tunnel entrance or proximal carpal tunnel is lateral boundary is formed by radial side is scaphoid and in ulnar side is pisiform bone. And distal carpal tunnel lateral boundary is trapezium tubercle and ulnar boundary is hook of Hammett. So you can see the ultrasound picture of proximal carpal tunnel. Here you can see this is scaphoid and this is pisiform. And one thing should be remembered, flexor carpi radialis, this is situated above the scaphoid. And these are the flexor tendon, median nerve, flexor retinaculum, and this is the distal carpal tunnel. Lateral boundary is trapezium and medial or ulnar boundary is hook of. So features mainly definitely there will be nerve entrapment, middle or advanced age. More than 40 years of age is more common. And in women, twice than men, and occupational disease also have.
Sir, sorry to disturb you. Your audio is a little low, sir.
Okay, I'm trying to increase volume. Now is it okay?
It's okay, but a bit low. But I think you are audible.
Okay. Thank you. So causes and contributing factors. There is wide range of causes of carpal tunnel syndrome, mechanical, and mainly job related. Those are cleaners, laundry makers, and slaughterhouse jobs involved with increased wrist flexion and extension, and consequently, that is result in increased carpal tunnel pressure. And space occupying lesion, this is also important. Bifid median nerve, you will have bifid median nerve, and you will have lipoma, peripheral nerve sheath tumor, even ganglionic cyst. So these are the space occupying lesions. And traumatic, here you can see the trauma maybe also there, the dislocation, fractures, inflammatory, flexor tendon tenosynovitis in case of inflammatory arthropathy like rheumatoid arthritis, gout, pseudo gout. Hormonal cause, those involved with increased fluid retention, that is pregnancy, obesity, renal failure, hypothyroidism, and heart failure, menopause, and oral contraceptive care. So neuropathy also may involve with carpal tunnel syndrome, diabetic neuropathy, hereditary neuropathy. And these are the rare cases. So lysosomal storage disorder, amyloidosis, acromegaly, and associations with persistent median artery of the forearm, cervical radiculopathy, brachial plasia. So motor innervation by the median nerve, first and second lumbricals, muscles of thinner eminence, and sensory innervation, skin of the palmar side of the thumb, index, and middle finger, half of the ring finger, and nail bed of this finger. On the right side of the screen, you can see the innervation area. But this area, that is thenar eminence, which is supplied by palmar cutaneous nerve, will be intact because palmar cutaneous nerve is arise before the carpal tunnel and it crosses over the flexor retinaculum. That is why if you have a thenar eminence sensation involved, then you have to think median nerve entrapment may be at the elbow, that is called pronator teres syndrome. So signs and symptoms, tingling, numbness, discomfort in the lateral 3.5 fingers, intermittent pain in the distribution of the median nerve. Symptoms get aggravated at night, holding a phone or newspaper or gripping a steering wheel. To relieve the symptoms, patients often flick their wrist as if shaking down a thermometer. And this is very important sign, flick sign, that is called flick sign. If you ask the patient how could you relieve your symptom, then patients will tell this is the flick sign. So motor changes, ape-like thumb deformity, loss of opposition of thumb, index and middle finger leg behind when making the fist, and thinner atrophy. Here you can see the thinner atrophy. This is bilateral thinner atrophy. So when you have thinner atrophy, then this is a severe case of carpal tunnel syndrome. That is motor involvement. So sensory changes, I have already told, loss of sensation of lateral 3.5 digits, including the nail bed, distal phalanx of dorsum of that. And the important point, what I told before, that is plumbar cutaneous branch, that is carpal tunnel syndrome, is that there is no sensory loss over the thinner eminence, as because the branch of median nerve that innervates passes superficial to carpal tunnel, not through. So you have to mind it. This area, that is the thinner eminence, there the sensation will be intact in carpal tunnel syndrome. And other changes also there, vasomotor changes, traffic changes. So diagnosis, signs, symptoms, and physical assessment, that is less sensitivity to pain, where the median nerve runs to the fingers, thumb weakness, inability to tell the difference between 1 and 2 sharp points, that is 2-point discrimination test. Click signal, I told before, that is the patient responds with a motion that resembles shaking a thermometer. The doctor can strongly suspect carpal tunnel. So another important test, phalanx test. Shruti already told about phalanx test. So patients twist the elbow on a table, the wrists down or flexion with fingers pointing down and the back of the hand. Positive if symptoms develop within a minute, CPS is indicated. You can also examine by this method. So tenal sign, although this is already told, you can use a hammer, again you can use your finger also, tap over the median nerve to produce a tingling or mild shocks. Durkan test, the doctor presses over the carpal tunnel for 30 seconds to produce tingling or shock in the median nerve. Hand elevation test, raises his or her hand overhead for 2 minutes to produce symptoms of carpal tunnel. These are the tests commonly we practice in our chamber: phalanx, tenal, hand elevation, flick sign. So another criteria is CTS6 diagnostic criteria. You can use this also. So CTS6, there's numbness in median nerve distribution is 3.5, nocturnal symptoms 0.4, thinner atrophy or weakness 0.5, phalanx test positive 0.5, tenals test positive 0.4, loss of 2-point discrimination, and this is for 0.4, 0.5. So total score, if more than 12, then you can suspect clinically this is the case of carpal tunnel syndrome. So severity of the carpal tunnel syndrome, how we can diagnose severity, because then treatment modalities depends on this severity of the mild, occasional intermittent symptoms during the day or night, including pain and paresthesia. Moderate frequent nighttime awakenings that affect sleep, frequent activity-related symptoms that do not impair function, and clumsiness, no weakness or sensory loss on physical exam. But in case of severe carpal tunnel syndrome, there will be thinner atrophy, weakness of thumb, abduction, reposition, constant sensory loss. So other tests, including electrodiagnostic tests, nerve conduction studies, electromyography. So for the pain physician, we are regularly we practice radiographic features, that is ultrasound, diagnose the carpal tunnel syndrome. So let's see how ultrasound features increase in carpal tunnel. So there are a lot of debate, a lot of publication, that is features of carpal tunnel syndrome. But personally, I follow three important parameters. One is plumbar bowing of the flexor retinaculum more than 2 millimeter beyond the line connecting the pisiform and the scapula, and distal flattening of the nerve. That is notch sign. You will be you have notch sign or hourglass sign. When ultrasound probe put a long axis of the nerve, then you will have this distal flattening or notch sign or hourglass sign. Enlargement of the nerve proximal to the flexor retinaculum. This is very important parameter for diagnosis of carpal tunnel. The enlargement of the nerve proximal to flexor retinaculum, you can measure by cross-sectional area. And latest ultrasound machines have this function, cross-sectional area. So here you can see the plumbar bowing, that is convexity, more convex of the flexor retinaculum. Here you can see the scaphoid and pisiform. So it will be more than 2 millimeters in connecting this line. And right of the screen, you can see the normal. This is scaphoid, this is pisiform, this is the line, and this is the flexor retina. So if you have this type of flexor retinaculum with clinical symptoms, then you may suspect this is the case of CTA. And distal flattening of the nerve. This is the long axis of the median nerve, and this is hypoechoic enlargement and notch sign. This is called notch sign or hourglass sign. And now enlargement of the nerve. There are also a lot of debate about cutoff value. So I personally follow cross-sectional area less than 8 millimeters. This is normal. Cross-sectional area more than 12 millimeters. This is pathological. Cross-sectional area in between 8 and 12 millimeters. Then you have to see difference between distal foramen and proximal carpal tunnel. If this difference more than 2 millimeters, then you will suspect carpal tunnel syndrome, and this is 99% sensitivity and 100% specificity. So proximal carpal tunnel, here you can see this level, you'll measure cross-sectional area. This is the median nerve, you can see, and you have to take the cross-sectional area at the proximal carpal tunnel, and at the level of distal foramen, here you can see the median nerve in between flexor digitorum superficialis and flexor digitorum profundus at the level of pronator quadratus, just starting point of the pronator quadratus, that is proximal part of pronator quadratus. At this level, you will take this cross-sectional area. Then if it is more than 2 millimeters difference, then you will suspect the carpal tunnel syndrome. So this is the distal foramen, proximal pronator quadratus level. So this is the pronator quadratus, and this is median nerve. And here you can take cross-sectional area, and this is 0.06 centimeters square. So next, proximal carpal tunnel. This is the proximal carpal tunnel because we have already told the proximal carpal tunnel is the scaphoid and pisiform level. So here, this is a scaphoid, and this is a pisiform bone. This is the median nerve. Here you can take cross-sectional area. This is the cross-sectional area. This is a 0.08 centimeters square. So this is the normal volunteer. That is why 2 millimeter square is the difference. If it is more than 2 millimeters square, then it will be a diagnostic value. So you can measure by this video. This starting from here. This is a pronator quadratus starting here. Then at the level of proximal carpal tunnel, here you can see the scaphoid. This is median nerve, and this is pisiform. We'll take measure of this area. So another important thing, you will have bifid median nerve with persistent median artery. In that case, difference will be more than 4 millimeters square. So if you have, this is the bifid median nerve, and this is persistent median artery. In that case, this difference, that is distal forearm and proximal carpal tunnel difference, would be more than 4 millimeters square. And you will have mass lesion, you will have lipoma, ganglionic cyst. So this is very important to scan before, even before surgery, because prior to surgery, if you miss this diagnosis, that is space occupying lesion like lipoma, cyst, then surgeon may miss these things. Surgeon may only decompression the flexor retinaculum. So this is very important to scan even before surgery. Even in case of persistent median artery, surgeon may injure this artery and decompression of flexor retinaculum. So this is very important to see the wrist area by ultrasound before any surgery also. So differential diagnosis of carpal tunnel as carpometacarpal arthritis, you will have painful thumb motion, positive brain test, radiographic findings, cervical radiculopathy, you will have neck pains, positive Sparling test, numbness of the thumb index finger, dequervance tendinopathy, tenderness of the distal radial styloid, peripheral neuropathy, history of diabetes mellitus, lower extremity involvement also. So a lot of differential diagnosis you have to exclude. You need to exclude all the things. So management part is first of all is conservative. That is immobilization by braces or splint. Stretching, strengthening exercise can be helpful in people whose symptoms have abated. And you can start with NSAIDs like aspirin, ibuprofen, and other painkillers. And you can give corticosteroids in the form of tablet or injection. Also, you can apply local injection. The non-surgical intervention is wrist stenting, activity modification, corticosteroids, injections, over-the-counter pain medication, physical therapy. Important consideration as severity of symptoms, patient assessment, and ergonomics, that is addressing workplace. So local injection case, you all know, that is we use usually lidocaine and methylprednisolone or tamsuline. So factors associated with failed non-surgical management include higher initial score on the Boston carpal tunnel questionnaire, symptom severity scale that do not improve, duration of symptoms greater than or equal to 1 year, a positive Phelan test, greater intensity of nighttime symptoms, tenor atrophy, more than one prior failed non-surgical intervention. These are the things you need to keep in mind in case of non-surgical management. So this, the Boston carpal tunnel syndrome questionnaire based on symptom severity scale, almost 55 score, and functional status scale is almost 40. So local injection, now come to the ultrasound. This is most favorite things for the pain physician. Ultrasound guided nerve hydrodissection. So usually I prefer hydrodissection technique by platelet-rich plasma, and 3 sites of hydrodissection. In short axis view, there is a posterior to the median nerve and anterior to that is above and below the median nerve. And in long axis, this is a fenestration also. You can give the flexoretinecolum fenestration and deposition of PRP. So I can see the one video here. So we are approaching fast below the nerve. This is the needle. Here, these are the flexor tendons, and this is the median nerve. Hydrodissect below the nerve first. Now come to the above the nerve and below the flexoretinaculum. So this is the flexoretinaculum or transverse carpal ligament. Now in long axis, from distal to proximal, third site of PRP deposition, and at the same time, you can make fenestration. This is the flexoretinaculum. You can make this also fenestration. So surgical and conservative management failed, then you can try surgery. There is open release surgery and endoscopic surgery. So complication of surgery, a lot of complication will be in your surgery. So, and another most important thing is exercise and rehabilitation. So don't forget after any procedure or any surgery, you should give exercise. This is carpal tunnel syndrome exercise. So this is all about carpal tunnel syndrome. So Shirish, everything is going well?
Yes, Mazhar, everything is going well.
Okay, thank you. So dequervance tenosynovitis. Now can say the dequervance tenosynovitis. So I'll be trying to talk on definition, anatomy, etiology, incidence, clinical features, diagnosis, examination, management, and also the ultrasound findings and ultrasound management. So dequervance tenosynovitis, all of you know, this is a chronic constrictive tenosynovitis affecting the abductor pollicis longus and extensor pollicis brevis tendon of the thumb at the wrist. So we all know that there are 6 dorsal compartments of the wrist. So this is the disease of first compartment that contains extensor pollicis brevis and abductor pollicis longus. So here you can see the 6 compartment. This is the first compartment, APL and EPB. Then this is a second compartment, extensor carpi radialis longus and brevis. Third compartment, extensor pollicis longus. And fourth compartment contains extensor digitorum and extensor indicis. And fifth compartment of the tendon is extensor digiti minimi. And finally, sixth compartment tendon is extensor carpi ulnari. So these are the dorsal compartment or extensor compartment of. So dequervance tenosynovitis is the first compartment tenosynovitis. This is the extensor pollicis brevis and abductor pollicis. So these are the origin insertion. Here you can see origin and insertion. I'm not going through. And etiology. Dequervance is named after the Swiss surgeon Fritz de Quervain, who first described it. Inflammation of the sheath or tunnel that surround 2 tendons that control the movement of the thumb. Main cause is repetitive use of the thumb in combination with radial deviation of the wrist, characterized by degeneration and fibrosis of the tendon sheath. So this is the pathophysiology, right? Repetitive movement or trauma, the increased friction, reactive fibrosis and thickening of the sheath, finally degeneration. So incidence occurs most often in individuals aged between 30 and 50 years. And at the same time, most of the disease, women are more common. And there is the same thing, women up to 6 times more often than men. It's commonly associated with dominant head. Clinical features, pain on radial side of wrist, that is worsened by moving the wrist or thumb. Tendon sheath may feel thick and hard. Swelling in anatomical snuff box. Acute tenderness at tip of radial styloid. And pain aggravates on grasping object. Which leader sign. Finkelstein test is positive. So this is the Finkelstein test. This is a provocative test used in diagnosis of dequervance tenosynovitis. Make a fist with the thumb inside. Now ask patient to bend the wrist toward the little finger. Differential diagnosis, there will be carpometacarpal arthritis, transverse fractures, intercarpal instabilities, scaphoid fractures, Waardenburg syndrome, C6 cervical radiculopathy, osteoarthritis of first carpometacarpal joint, intersection syndrome. So examination, resting posture of hand, on observation, you will see the resting posture of the hand or thumb, inflammation around dorsal part of the base of the thumb, and on palpation, tenderness over the base of the thumb and first dorsal compartment, thickening of synovial sheath, and range of motion. You You have to see the cervical range of motion, shoulder, elbow, forearm, wrist, everything you have to cross. And fist grip strength will be less. Pinch strength, neurological test. So almost all of the test examination you should take. Radiological findings. In X-ray, you will have soft tissue swelling of a radial styloid. You can see here, this is the soft tissue swelling, right? This is the soft tissue swelling. Here you can see here, now this is expanding. And cortical erosion and sclerosis. You can find in radial styloid, there is cortical erosions and sclerosis. Now, ultrasound findings. In short axis view, this picture will show the tendon and peritendinous effusion is there. And this is the extensor retinaculum, which is thickened. And extensor retinaculum thickened will be seen in more clearly in long axis. This is the long axis view of the tendon. And this part is extensor retinaculum. And in case of decurvent stenosynovitis, you will have thickened extensor retinaculum. So increased fluid in tendon sheath, hypoechoic edematous tendon thickening of extensor retinaculum. So this is the clearly seen lot of fluid around the tendon. Even if you apply power Doppler, you'll get hyperemia. So management goals of treatment: restoration of normal, painless use of involved hand, resolution of inflammatory process, prevention of recurrence, restoration of pain-free movement and strength. The medical management, corticosteroid injection can be given to patients with moderate to marked pain with symptoms lasting for more than 3 weeks. NSAIDs, it is prescribed initially to reduce pain and inflammation. Physiotherapy management, immobilization, cold compression, ultrasonic therapy, phonopharesis, so strengthening, stretching, strengthening exercise. The ultrasound guided injection and fenestration of extensor retina. So here you can see, before that, you need to know that this picture, this is a Lister tubercle. The Lister tubercle separate the third compartment and second compartment. So first of all, your probe should be placed over the bony prominence, that is Lister tubercle.
What is this, sir? This is distal tubercula.
Lister, I'm telling Lister tubercle.
LIS?
Yes, LIS. Yeah. LISTER. Clear? Lister tubercle.
Okay, sir.
So this is the Lister tubercle, and this is third and second compartment. So place the probe over the Lister tubercle, then try to see third and second compartment. Then from second compartment, move the probe radial side. Then you will see the styloid process. Then you will see first compartment. To place the probe, this is the over the Lister tubercle, and this is the Lister tubercle. And in your ulnar side, you will see the third compartment, and in radial side, you will see the second compartment, two tendon of second compartment. All of you know third compartment for single tendon, extensor pollicis brevis, and second compartment, two tendon, extensor carpi radialis brevis and longus. So this is third, this is second. Now focus on second compartment only and move the probe radial side. And then you will find here styloid process, then first compartment. So just like that, you'll see second compartment and styloid process now come to the first compartment. So here you can see the first compartment and radial artery also you can see. So this is the two tendon you'll find first compartment at PL and EPD. So you can see just place the probe over the Lister tubercle. Here, this is the bony prominence. This is the Lister tubercle. So this is third, and this is second compartment. Now move the probe radially, and this is styloid process. Now here you can see the first compartment. Yes, this is the first compartment tendon. Yes, this is the first compartment here. One is APL and another is EPB. This most ventrally, this is APL and dorsalis. Injection technique, that is short axis and long axis. Both way you can approach in case of in-plane technique. But you can use also out-of-plane technique. And personally, I prefer if there is no separate tendon sheath, I mean septa. I'm telling septa. Sometimes you will have septa separate the two tendon. In that case, if you use implant technique, then you will miss the two tendon at the same time. In that case, you can use autoplan technique in between two tendon in the septa. So sometimes you will have septa. Yeah, you should identify whether there is a septa present or not. So you can see the video. Third axis approach. This is the tooth tendon.
That hyperlucent bone is scaphoid bone, sir.
Sorry?
The bone hyperechoic line. Yes.
Yes, this is the radial styloid. This is the radial styloid, and this is the first, yes, this is the first compartment, right? So you can approach from here. This is the needle, and in between tendon and this is the extensor. This area is extensor retinaculum. So in between tendon and extensor retinaculum, your needle trajectory should be in this. Now we can see the long axis. Here you can clearly see this is the extensor retinaculum is thickened. This part is up to this level, this is tendon. This is the radius. You can see the radius over it. This is this two tendon. One is from here to here and another one. This tendon up to this level, but this area you can see the thickened extensor retinaculum. So your goal is to fenestration of this extensor retinaculum in long axis view. So your needle trajectory should be in that area. This area, you can fenestrate this thing. So you can see the fenestration. So after conservative management is failed, then we'll go for surgery, decompression surgery. After 2 days of surgery, immobilization with cast, this is the post-surgical management. Okay, thank you for patient sharing. Thank you so much. Any question?
Thank you, Mazhar. Very, very nice and detailed presentation. Always love your presentation.
Thank you, friend. Thank you so much. You are
So any
lovely.
question for Mazhar? Dr. Mazhar?
Tell please again.
Any questions for Dr. Mazhar? So I just want to add one thing, okay, in Mazhar's slide regarding carpal tunnel syndrome hydrodissection. Nowadays, 5% dextrose is also giving a very good result. So apart from steroid with local as well as PRP, where Dr. Mazhar is doing very nicely, and his results are also very good. But there are lots of papers which is saying that a 5% dextrose injection around the median nerve for hydrodissection is also having a very promising result and long-term result. So you can also add 5% dextrose hydrodilatation in, especially in carpal tunnel syndrome hydrodissection. Okay. Anything you want to add, Dr. Smruti?
Yes, sir. Many congratulations to Dr. Vayan, sir, and Dr. Mazhar, sir. It was wonderful presentation from both of you.
My
And
pleasure. My pleasure, Shruti. Thank you so much.
most welcome, sir. Most welcome. So, Siri, sir, can we? Okay, there is a question in the chat box that, sir, how long effect of dextrose 5%? This is a question to Mazhar, sir.
Yes, you can use 5% dextrose, you can use PRP, even you can use normal saline. A lot of papers also there. You can use lidocaine also. So main thing is to hydrodissection of the nerve. And in my practice, I usually prefer PRP hydrodissection. Even I encounter a lot of patients with thinner atrophy, that is motor involvement. And in that case, PRP hydrodissection worked very well. So in case of 5% dextrose, also very effective, what she is told. And usually you can use 3 to 4 session, that is 3 to 4 weeks interval. And this is effective. And definitely what I told, that is the assessment is very important. Other severity, mild, moderate, and severity. So if you use hydrodissection in case of severe carpal tunnel syndrome, there might be success rate will be very less, I think. But in case of mild to moderate carpal tunnel syndrome, hydrodissection by anything, that is normal saline, lidocaine, dextrose, PRP, that result will be very good. Thank you.
Sir, one more thing I want to add, that with 5% dextrose hydrodissection or median nerve, recurrence rate are quite low if we will do hydrodissection along with the fenestration of the flexure retinaculum.
Yes.
And even it has been shown that there are many evidence and many research paper came that it is superior to surgery of the for carpal tunnel syndrome. Success rate is better with fenestration, with hydrodissection than surgery.
Agree with you.
Hello, ma'am. I have one question to ask.
Yes, please.
In case of hydrodissection with 5% dextrose, how many times we have to give the injections, and after after which interval?
Okay. So first of all, once you do hydrodissection of the median nerve, if the patient will not come to you, most of the time what I have seen in my OPDs also, usually they do not come because most of the time it's entrapment. Basically, it's an entrapment neuropathy and it is relieved with the 5% dextrose hydrodissection. If the patient will come again, then you can do at an interval of 3 months, 6 months, you can do. But usually
okay.
recurrence rate is very low.
Okay. Even with a single injection?
Yes, with a single injection.
Okay. Thank you, ma'am.
Most.
Okay, I think we should call it a end of this session. See you next week. And thank you again, Mazhar, Smruti, for the wonderful presentation. Good night.
Thank you so much, Siri sir. Good night. Good night, everyone.
Thank you.
Good night,
Thank you,
sir. Good night, ma'am.
Good night.
Good night, sir.